This is the day 2 summary of the HICPAC meeting on November 3rd, 2023. Before I do a breakdown of the full meeting and then do comments on the public comments, I need to do a quick aside on language and why language is important and why it is powerful. Initially, you might think this is just semantics, but it's not. So I work in medical devices and we do things called product requirements, and we do risk analysis and hazard analysis. And when we do this, we have certain language that has to be said for certain types of requirements, where the language can essentially be tiered. The highest level, we'll call this tier 1, is must, need to, shall. Tier 2 language, one rung down, is something like should. And tier 3 language, the bottom rung, is something like can or may. So briefly, let's give a very common day example to talk about the difference between these different phrases or different word usage. Let's pretend you're a parent talking to your child, and you say, you shall clean your room by 5 p.m. tonight, or you need to, or you must clean your room by 5 p.m. tonight. This is a set requirement that has a specified deadline and is something that must be done, otherwise there will be consequences. Now let's switch the language up. So you should clean your room by 5 p.m. tonight. It sounds tough, but instead of a requirement, it's a I think this is a good thing that you should do, but there's no consequence if you don't do it. It's more of a nice to have. And then we'll go to tier 3. You can clean your room by 5 p.m. tonight, or you may clean your room by 5 p.m. tonight, which is essentially saying, the choice is completely up to you. I really don't care. So now that we have this background, we can go through all of the changes that happened during this meeting. The first downgraded requirement was that respirators were downgraded from must be cleaned to should be cleaned, which, as we learned, takes it from you have to do this to we would like it if you do this. Next, we had respirator changing, downgraded the language as well. And here we have to talk about the difference between contaminated and soiled. You can contaminate yourself by coming into contact with a respiratory pathogen, such as COVID, by just being in the room. This is a contamination event. However, something being soiled, so if your clothes went in the room, you're wearing a mask, your mask would be contaminated with COVID particles from being in that room. So then you would have to change it. So changing language from contaminated to soiled. So if something is soiled, you can visibly see something. So COVID particles are small. You can't necessarily visibly see those. But if something is soiled, it means that someone has literally like spit on you or coughed on you, or there's blood that got on you. So that's a higher requirement to meet for changing. So in terms of respiratory devices being changed, this language was downgraded from when they become contaminated to when they become soiled, which means that providers are going to be like, well, your mask isn't soiled, so we're not going to provide you with a new one to replace your mask, even though it is contaminated. Next, for transmission-based protocols, the language is set up that you would use appropriate transmission-based protocols at the time a patient develops symptoms or signs consistent with a transmissible infection to reduce the transmission risk. The problem with this is that people can be infectious prior to having symptoms, which completely also ignores asymptomatic presentation, where you are infectious but are not even showing symptoms during the time you are infectious. This is another clear downgrading of the language because you're only taking precautions if you perceive someone as being sick, and also if you perceive it as a respiratory illness and not something else. For routine air precautions, the language was downgraded once more. For a mask is worn by healthcare practitioners on entry to a room, it was downgraded to healthcare practitioners should use a mask on entry to a room. And for the special air precautions, it was again downgraded to healthcare practitioners should use a NIOSH-approved fit tested N95 or higher respirator and eye protection on room entry. And this was similar language in the extended air precautions. Another one was source control should be used by the patient when they leave their room, but source control wasn't fully defined. Is the source control masking? How are you defining this source control? What happens if a patient refuses to use source control? And within the definition of the source control, they eliminated the word masking. also downgrading the requirement for this source control as being measured based on a facility risk assessment. So the hospitals can define what the risk level would be to be wearing these masks. Another downgrading was in patient placement, where the language was downgraded from anytime room sharing occurs, practices need to be in place to limit potential for cross-contamination, including access to hand hygiene supplies, changing PPE between roommates, and dedicated patient care items, or cleaning and disinfecting shared equipment after each use. This was again downgraded to should be in place. And the most egregious example, while these are all terrible, was in transport of patients, where for healthcare workers transporting an infectious patient, they only have to use a mask if the patient requires medical care during transport. Otherwise, they can just carry it on their person. And this is also if the patient is unable to wear one, but then again, what happens if the patient refuses to wear one? And they're also mandating that a person to be pressing the buttons and whatnot should not be wearing PPE whatsoever, but they should be at least able to wear a mask while they're guiding the transport of this patient. And that was sort of a summation of the major downgraded language in the HICPAC guidelines for protections for healthcare workers and PPE usage. Now I'm going to try to blast through these public comments. Cypher El Masi says that we need to develop training plans for diverse healthcare settings. We need to cultivate safety leadership in the healthcare industry. We need to work with unions, professional societies, communication specialists, and patients, as well as healthcare workers. We need extensive occupational safety campaigns and public service announcements, and we need ventilation and elastomer-based masks, and we need to delay the HICPAC vote. Aisha Mirza, part of the World Health Network, says we need to be using respirators over surgical masks in healthcare. We need implementation and prioritization of clean air, and we need a reinstitution of accurate testing and appropriate isolation practices and mitigations. We need to delay the vote. Rachel Nussbaum did an impassioned statement where they said that they only had one COVID infection and they now have POTS. Kathleen Turtwise, part of the World Health Network, stated that on October 29th, they filed a formal complaint to the Department of Human Health Services, the Office of the Inspector General, that HICPAC is in violation of the Federal Advisory Committee Act and are in violation of their own charter and membership plan, where it is stated that they need 14 members that are fairly balanced in their point of views. There are only 9 members, so they have no legal standing, and they have no voting member that's an expert in aerosol science, ventilation engineering, industrial hygiene, ultraviolet light, HEPA filtration, respiratory protection, or occupational health and safety. Their membership is therefore not fairly balanced as required by law. That HICPAC has failed to provide records to the public in violation of the FACA and charter, thereby obscuring its process of making updates. Then there's Kevin Kavanaugh, part of Health Watch USA, saying that the comparison between N95s and surgical masks being equivalent in the HICPAC guidance is inadequate for influenza and coronaviruses, that we need negative pressure rooms, which are not promoted. We need enhanced barrier protections. The air quality standards are lacking. There's a complete lack of provisions for screening of these pathogens. And the quote that I really liked was the backpedaling of standards has often been justified by the imposed burden of increased preventative strategies would place on facilities, and that is not okay and it's not appropriate. And Miller, Project N95 director, says they need to operate with transparency, add voting members and stakeholders, make this a collaborative effort. They need to simplify air precautions, not just in acute care settings, and they need to codify the use of N95 respirators or equivalent into standard precautions, and they need to delay the vote. Darius Sylvan said that the full draft of isolation guidance was only available for review prior to the vote, that there was not time for patients and experts to comment on the full draft, that in the presence of unknown factors, unknown diseases, we need a high level of respiratory protection like N95s, but the current guidelines only call for special and not extended practices, and that the phrase for readily available PPE is one that employers can use to get out of providing it. Lisa Broskin, an industrial hygienicist, stated that inhalation can occur both near and far from a person infected. HICPAC fails to recognize this, and Victoria Berker, a retired nurse practitioner, was told to come in COVID positive.